management of the advanced stage epithelial ovarian cancer, FIGO stage 2 to 4. The historic treatment paradigm for women diagnosed with the advanced epithelial ovarian cancer is a model in evolution. Recently published data of the NCI indicate that only 15% of the women diagnosed with localized disease stage 1 with which have a 5-year relative survival rate of approximately 92%, and 18% of the patients with the regional spread of the disease to adjacent pelvic organ FIGO 2 have a 5-year relative survival of 71%, and for 61% patients disease has spread to the distant organ in the abdomen or lymph nodes FIGO stage 3. 5-year relative survival is only 27%. Investigators of the Center for Disease Control and Prevention have reported mortality trends resulting from the ovarian cancer from 2000 to 2009, noting that death due to this disease have decreased significantly by 1.5% per year among women all over and among non-Hispanic white women. Mortality rate among Hispanic women were found to have decreased significantly by 1.1% per year. Mortality rates have remained stable among African American, American Indians, Ashkenazi Native, and Asian Pacific Islander women. So patients often present with an constellation of symptoms consistent with the advanced disease. Most patients undergo radiographic imaging and most commonly pelvic ultrasound, CT imaging, and a definitive diagnosis often made at the time of surgical exploration. Cytology from abdominal paracentesis, histological confirmation through CT guided biopsy of a metastatic disease site is also informative. Cytoreductive surgery, chemotherapy, they are required for majority of the cases of the advanced stage. And paradigm is to operate prior to administration of the 6 to 8 cycles of adjuvant platinum and taxane based systemic therapy. This approach has been revisited during the preceding decades as the definition of what consists in optimal cytoreductive surgery has evolved among the feasibility of neoadjuvant chemotherapy. An important area of the study involves mapping the mutational landscape of the histological subtypes of the disease. 75% of the women with the advanced disease can enter remission after the surgery and chemotherapy. But due to acquired drug resistance, majority of the patient will relapse, ultimately die from disease. 10-year disease-free survival ranges from 5 to 10%, and significant strides have been made with the incorporation of the targeted therapy in management algorithm for advanced ovarian carcinoma, and FDA approved and regulatory approved abroad, having granted for anti-angiogenesis therapy and integration of the PARP polyadipyribose polymerase 1 PARP inhibitors, and randomized trials in the field of the immuno-oncology using checkpoint inhibitors also ongoing. And although targeted agents have been studied for the primary therapy in recurrent disease, notably emerging role have actually be a maintenance therapy after complete response or partial response to standard chemo. And for this reason, targeted agents are discussed separately after detailed review of the chemotherapy agents. So, subtypes of ovarian cancer and associated genetic change, mutations, high-grade serous, there are P53, BRCA, RAD51C, RAD51D, and BARD1, PALB2. For low-grade serous, it is KRAS, BRAF, ERBB2, and PIK3CA. KRAS, BRAF, ERBB2, PIK3CA. For endometriosis is ARID1A, CTNNB1, P10, PIK3C, and PPP2R1A. And for clear cell it is ARID1A, PIK3CA, ZNF217, PPP2RIA. and mucinous is KRAS.